We'll move on to the next presentation, that's timing of surgical referral for valvular heart disease. A stitch in time saves 9. Our invited speaker for the next 12 minutes, followed by 3 minutes of discussion, is Dr. Alok Kumar Singh, Senior Consultant Interventional Cardiologist from Lifeline Hospital, Varanasi. To help Dr. Singh be on time, we have a timer straight across. Over to Dr. Singh. Thank you.
Thank you. Very nostalgic feeling to speak in front of our teachers. So the topic is when to refer the patient for surgery in valvular heart disease. And earlier, valvular heart disease means only two options, medical therapy and in most of the cases only surgery. But in last decade, transcatheter therapeutics have shown a lot of promise in the management of aortic stenosis. Mitral stenosis, balloon mitral valvotomy was a well-established treatment, but with the introduction of TAVI and transcatheter edge-to-edge repair, MitraClip, have revolutionized the management of valvular heart disease. So new specialty among the cardiology, like valvular heart disease, have shown the promise. Because of that, the comprehensive evaluation of valvular heart disease have taken the center stage. Earlier, it is like a neglected. Any valvular patient comes to our clinic, we used to go diuretic and diastasis, and when become very severe, then refer to for surgery. So ESC recommends and ECC recommend to establish the comprehensive heart valve centers, followed by heart valve clinic, and there should be very comprehensive clinical and imaging assessment, clinical evaluation. Biomarkers have taken the very important role, BNP especially in aortic stenosis patient, stress testing in asymptomatic severe patients, comprehensive echocardiography, transthoracic and transesophageal, CT scan. CT scan is very important tool for in the management when considering from TAVI and CMR and stress testing. And life expectancy is very important. If life expectancy is less than 1, then any surgical and valvular intervention tend to be futile. And apart from that, optimal local resources, availability and expected outcome of given intervention at a given center, operative risk, assessment of comorbidities, marker of progression in asymptomatic patients, individual anatomical and procedural factors, value and expectation of the informed patient. So afterward, heart team decision by surgeon, interventional cardiologist, clinical cardiologist, imaging specialist, and also informed consent of the patient. So shared decision making now a norm in management of valvular heart disease. And just to summarize, because surgery have a lot of mortality, and if you see mitral valve replacement plus CABG, mortality rate is 9%, and AVR and MVR combined 9%. So careful selection of patient and referred for surgery at the optimal time is very important, because these procedures have carried lot of mortality. So I will come one by one. Aortic regurgitation. So comprehensive assessment of aortic valve regurgitation should be done. It should be qualitative, semi-quantitative and quantitative. And qualitative valve morphology, color flow regurgitation jet area, CW signal of regurgitation jet, if it is dense, it shows severe, and hollow diastolic flow reversal in descending aorta, and diastolic velocity, if it is more than 20 centimeter per second, then it signifies severe aortic valve regurgitation. Vena contracta more than 6 mm, pressure half time less than 200, and effective regurgitant of orifice area if it is more than 30, regurgitant volume more than 60, and if LV is dilated, then probably you are dealing with the severe. Once it's severe aortic valve regurgitation, then you should consider for the surgical intervention. So surgery is recommended in symptomatic patient regardless of LV function. So severe and symptomatic, class 1 indication. And apart from that, asymptomatic severe, if LV and systolic diameter more than 50 mm or resting LV ejection fraction less than 50, then it is a class 1 indication. And apart from that, if any severe AR patient is going for any other surgery, cardiac surgery, like CABG, then again it becomes a class 1. So surgery, symptomatic, severe symptomatic surgery, going for surgery, and systolic diameter are increased, then this becomes the class 1 indication. Apart from that, if there is a borderline decline in LV ejection fraction or borderline increase in LV and systolic dimensions, then class 2B indications. And valve-sparing aortic root replacements are recommended in young patients with aortic root dilatation if performed in experienced center and durable results are expected. Ascending aortic surgery is recommended in Marfan syndrome if aortic root more than 50 mm. Just to summarize, management of patient with aortic regurgitation, if there is a significant enlargement of ascending aorta, so if it is more than 55 mm, in most of the cases, aortic valve sparing surgery should be done. If symptomatic, severe symptomatic, then class 1 indication. If symptomatic, severe and LV ejection fraction less than 50%, according to ESC, it is surgery. And if it is LV and systolic dimension more than 50 mm, then it is surgery. Otherwise, medically it should be managed. Likewise, aortic stenosis, if echocardiography is significant aortic stenosis, you have to assess the gradient. If it is a high gradient aortic stenosis, Vmax more than 4 and mean gradient more than 40, it is severe aortic stenosis. If it is a low gradient, then you have to look for the planimetry aortic valve area. If it is less than 1, then it is probably significant. Then look for the flow status. If it is a normal flow, then severe AS is unlikely with the low flow, low gradient. If it is a low flow, less than 35 less than, and if it is more than 50% ejection fraction, then integrated approach should be done. Means cardiac CT for calcification, BNP increased should be seen. And if it is not like that, then DSC flow reserve should be seen. And again, aortic valve area, if it is less than 1 in low flow, then severe AS. If it is not like that, then it is pseudo-severe AS. And in aortic stenosis, TAVI is now very strong option being taken because of its non-invasive nature. So if patient is low surgical risk, then surgical is preferred. If higher surgical risk, TAVI is preferred. Younger age, surgical valve replacement is preferred. Older age, TAVI is preferred. Previous cardiac surgery, TAVI preferred. If patient is frail, TAVI is preferred. Active or suspected endocarditis is there. Presence of thrombus is there. Then surgical replacement is preferred. Otherwise, if there is a history of chest radiation, porcelain aorta, and high likelihood of severe patient prosthesis mismatch is there, then TAVI is preferred. And significant multivessel CAD requiring surgical revascularization, surgical is referred. If associated mitral valvular disease and tricuspid valvular disease is there, then again surgical is referred. If there is significant dilatation and aneurysm of aortic root and ascending aorta, apart from that, if there is a massive septal hypertrophy is present, again surgical is preferred. So intervention is recommended in symptomatic patient, symptomatic severe aortic stenosis, class 1 indication. Intervention should be considered in symptomatic patients with low flow, low gradient severe aortic stenosis. Just to summarize, if LV ejection fraction less than 50% severe, symptomatic and patient going for any other surgery, patient should be considered for by heart team, and depending on the patient characteristic, as I have discussed earlier, TAVI versus surgical replacement should be considered. Mitral regurgitation, first by echocardiography, comprehensive echocardiography and history, we have to differentiate whether we are dealing with the primary mitral regurgitation or secondary, and afterward, mitral valve repair should be the recommended surgical technique when the results are expected to be durable by experienced surgeons at experienced centers. So again, the concept is severe symptomatic is a class 1 indication. And if LV ejection fraction is less than 60%, AS and AR it is a 50, here it is 60, and LV and systolic dimension here is 40 and above, in AR it was 50 mm. So these are the class 1 indication. And in secondary mitral regurgitation, guideline directed medical therapy of heart failure should be given, and after guideline directed medical therapy optimized, CRT when indicated, and if there is no severe comorbidity limiting life expectancy less than 1 year, then after consideration for everything, if still severe mitral regurgitation after optimal medical therapy is there, based on the data of COAPT trial, S2S repair should be considered, or mitral valve replacement. Mitral stenosis, again, there is a lot of sea change in the definition according to American College of Cardiology. Earlier severe mitral stenosis was less than 1, but now it is less than 1.5. So any severe mitral stenosis, symptomatic, severe means less than 1.5, earlier it was less than 1, should be subjected to BMV if patient valve is suitable for that. If it is not suitable, then mitral valve replacement should be done. Lot of scores are there, Cormier scores, Wilkins score and echocardiographic score to assess the patient's suitability for the balloon mitral valvotomy. So PMC is percutaneous mitral chemosterotomy should be the first approach when valve is suitable and there is no contraindication like LA thrombus, more than mild mitral regurgitation, severe or bichemical calcification, and severe concomitant aortic valve disease and severe combined TS and TR or concomitant CAD. If these things are not present, then BMB should be first approach. If these things are there, then valvular replacement should be done. So severe mitral stenosis is there. LV ejection fraction is not any criteria in mitral stenosis. We have to keep remember. Like in tricuspid valve, again, severe tricuspid regurgitation should be treated with the surgery. So surgery is recommended in symptomatic patients with severe tricuspid stenosis. Surgery is recommended in patients with severe tricuspid stenosis undergoing any left-sided intervention. So any valvular lesion for all practical purposes, if it is severe and symptomatic, then it should go for surgical option or interventional option, whatever suits. And recommendation for secondary TR, surgery is recommended in patient with severe secondary tricuspid regurgitation undergoing left-sided valve surgery. It is a class 1 indication, and transcatheter treatment of symptomatic secondary severe tricuspid regurgitation may be considered in inoperable patients at a heart valve center with expertise in the treatment of tricuspid valve diseases. It is a class 2B indication. So summary, if you see, for all practical purposes, this is 5 ways. Severe, if it is a severe, symptomatic. So among all, whether it is AR, AS, or MS or MR or TR or TS, it will be class 1 surgical indication. And if there is a systolic dysfunction, in the case of regurgitant lesion, LV ejection fraction cutoff is 50% for aortic stenosis and secondary mitral regurgitation and AR as per European Society guideline. And in ACC guideline, the cutoff in AR is 55% for the class 1 indication. And for mitral regurgitation, LV ejection fraction 60% and systolic dysfunction is 4th, AR and MR, LV and systolic dimension 40 mm for mitral regurgitation, 50 mm for AR. And when patient is going for any surgery in AS and AR, then there is an indication for surgery. It does not hold true in the case of MS and MR because MBR plus CABG have a mortality in the tune of 10%, 9 to 10%. That is the reason. So thank you all for patience hearing.
Thank you, Dr. Alok. Nicely presented with every valvular heart disease. Now, repair is there, medical therapy is there, replacement is there. When you are going to do the angiography, all patients or 40 or 30?
Actual recommendation is all patients, valvular heart disease patients, 40-year age and above should go for the invasive coronary angiography. Invasive coronary angiography is a class 1 indication. Level of evidence is C. Basically, it is based on consensus. But now CT coronary angiography also have been given class 2A recommendation to rule out CAD.
So all symptomatic stenotic patients.
Any
Because
patient
in
above
India,
age 40,
majority of the
it is a
patient
routine to go for angiography.
India, majority of the patient come to you only once they are symptomatic.
I'm not.
In India, surgical indication may be found in almost all patients because they usually report to the cardiologist when they are symptomatic.
Yeah, that's all. Guideline is if any severe valvular heart disease and symptomatic. So for almost all valvular lesion, it is a class 1 indication. Because of improved surgical results, now earlier intervention is being recommended. So mitral stenosis, when we used to do DM, it was a 1. Now it is a 1.5. And 1.5 to 2 is progressive MS.
Any comments from? Yes, Doctor.
Can I ask one question before that?
Yeah,
Well summarized, Alok, especially the last slide was really good. Just one quick question. I think just before the publication of the latest guidelines, there was a study published in JACC which had shown that a symptomatic aortic stenosis rather than waiting, we could go ahead with surgery, those patients fared well. probably that study could not be incorporated. I think it was just on time.
I
or
think
something.
asymptomatic severe aortic stenosis, there are 3-4 things they have recommended. Like if it is a severe calcification on CT scan, if
No,
right
sorry, can I interrupt? The calcification, what we used to follow in the UK population was that, so when the patient was symptomatically and severe, there is calcification is of course for planning the surgery, that is different. When the patient was in grey line, grey line in the sense, you are not getting severe echocardiographic features, but at the same time when the calcium score was more than 4,000, 4,000 was the cutoff, sorry.
and BNP level is also more than 3 times is also one concentration.
Okay,
Only
Mr.
one
Chairman.
comment, very small.
Yes.
We always talk of the individual lesions in India. It is not so in our country. You know. We get multiple lesions combined.
Yes, sir.
So what is the exact timing of the surgery in the multiple lesions? One, in the combined lesion, MSMR or ASAR, or with atrial fibrillation.
Sir,
These are the things to be considered in our country specifically. These data are all probably made in the Western countries where rheumatic heart disease has gone or is not there. But in our country, rheumatic heart disease still persists and there are combined lesions.
yes, sir.
So these guidelines are all, they get pasted. Then on that point of view, Mr. Chairman and you, what would you like to comment?
So actually, if multivalvular lesion is there, and if one lesion is severe, and if another lesion is, another valvular lesion in different valve, if it is moderate or more, then probably you have to go for double valve surgery. And if you are, suppose you are dealing with AR, aortic valve lesion with mitral stenosis, and mitral stenosis can be taken care by balloon mitral valvotomy, then probably rather than putting 2 valve, we can perform the BMB of mitral stenosis and we can do there. And now because of increased life expectancy, degenerative mitral valve disease, and we tend to see lot of calcific MS in elderly population nowadays, which are usually associated with the mitral annular calcification, more of variety.
Yeah, I'm sorry
Dr.
for the interruption.
Thakur, please.
We'll
Yes,
have
your
to
comment.
move ahead because we have run out of time for...
Okay, one comment for Dr.
Thank you, Dr. Alok, for enlightening us about the individual valvular heart disease. What I realized in my last 35 years of practice in valvular heart disease is that it basically intervention, that is be it lab intervention or surgical intervention, depends primarily on 4 things. One is presence or absence of symptoms. Second is severity of the lesion.
Yes, sir.
By severity I mean whether it is producing any hemodynamic compromise or not. And third, that is impending LV dysfunction, not florid LV dysfunction.
Yeah, yeah.
Florid LV dysfunction is so obvious that can be diagnosed by a technician. Impending LV dysfunction. And fourth is the presence or absence of complications.
Yes.
So if we consider these four parameters in mind, symptoms, severity, impending LV dysfunction and complications, I think we will not have any difficulty in any type of lesion, whether it is isolated or mixed,
Yes.
to reach a conclusion whether he requires intervention or not, be it in the lab-wise or be it surgical.
Yes.
The commonest example which you kept on repeating time and again was aortic valve stenosis. I would like to highlight that in arena of aortic valve stenosis, if it is bicuspid aortic valve, then symptoms are very, very important. But in degenerative aortic valve stenosis, where there is a very high potential for confounding factors like COPD, associated coronary disease and all, relying solely on symptoms is perhaps not wise. So we have to rely on severity, impending LV dysfunction and presence or absence of calcification.
Yes,
so if we keep these 3 or 4 factors in mind, I don't think we will need any sort of revision with guidelines, the parameters and
Yeah,
so on and so forth.
Okay.
Thank you.
Thank you very much.
Chairman, we'll have
Thank
to
you,
move
Dr.
ahead.
Alok.
Thank you very much, Dr. Singh. With the permission